So the diabetic foot ulcer, what happens is gradually it affects many organs. At the same time, it affects also the nerves and this.
In India, how many patients are right now suffering? How many percent?
Millions of patients are suffering from diabetic foot ulcers. Yeah, most of the time you will be surprised to know that the patient comes to our clinic with a small ulcer in the foot and we tell them, are you diabetic? First thing they say, no, I am not diabetic.
How neuropathy contribute to developing diabetic foot ulcer?
Yes, as I have said, neuropathy actually means there is the involvement of the peripheral nerves. So hence the patient who are diabetes and the nerves are involved, they are not aware of any small trauma to their foot. They are not aware of there is any crack in the foot.
What is the role of ankle brachial plexus index?
So if the ratio is less than 0.9, then we call it the patient might be having.
But basically due to the improper weight,
Yes.
ulcer forms.
So what is happening? Our pressure on these muscles and
Namaste, welcome you all to our new episode of Healthy Roots of India. In this topic, we are going to discuss about diabetic foot ulcer and its rehabilitation approach. So, in diabetic foot ulcer, we are going to discuss about what is diabetic foot ulcer, what is the risk involved in diabetic foot ulcer, what are the prevention things we have to do, what are the wound management techniques available, what are the surgical things we can do, and how we should educate ourselves for the diabetic to prevent the diabetic foot ulcer, and most importantly how we can rehabilitate foot ulcer. So to discuss about this diabetic foot ulcer and its management, today we have invited our guest Dr. Alok Majumdar. Dr. Alok Majumdar is a general surgeon who is practicing in Visakhapatnam since more than 20 years of experience in the field of general surgery. So in his career, he has treated a lot of patients who are suffering with diabetic foot ulcer. Let's welcome him to our podcast and know more about diabetic foot ulcer and its management. Welcome, sir. Welcome to Healthy Roots of India. As you know, sir, today the topic of discussion is diabetic foot ulcer and the rehabilitation approach towards it. So we'll go step by step and discuss more about the diabetic foot ulcer and what is the management, how we can rehabilitate it, and so many things. Sir, my first question is that what is the prevalence, diabetic foot ulcer prevalence in India, and what are the impacts of quality of life after suffering with diabetic foot ulcer?
Thank you very much for calling me in the Health Heroes of India. There's a very good question. The prevalence of diabetic foot ulcers in patients who are diabetes ranges from 16 to 60%. What does that mean? That suppose a patient is diagnosed with diabetes, in his lifetime, this is the range of percentage he might have developed diabetic foot ulcers.
Okay.
Not all patients will develop. If you are able to control your diabetes, take care of your foot and the other things associated with it, then you might not develop diabetic foot ulcer throughout your life. But if you are negligent, you don't take care of your foot, you don't take care of your glucose levels, then you might develop diabetic foot ulcer in your lifetime at any point of time.
Okay. In India, how many patients are right now suffering? How many people are suffering right now?
Millions of patients are suffering from diabetic foot ulcers. We daily on a routine basis see diabetic foot ulcers in our clinic, and the most important thing is that the patient who come to us with diabetic foot ulcers have somehow neglected this diabetic foot ulcer for a long time, or neglected the symptoms that the patient develops for a long time.
Okay.
And they come quite late to us. So I think with this podcast, we should be able to educate more people that show that they should come to us early so that we can prevent them. And also those people who are having should come to a proper hospital to get a proper management and rehabilitation program.
Yes. Sir, as right now in India, maximum people are suffering with diabetic, then it ends with the diabetic foot ulcer and many other diseases due to diabetic. So, what are the primary risk factors involving in diabetic foot ulcer?
Yeah, so the diabetic foot ulcer, what happens is gradually it affects many organs. At the same time, it affects also the nerves and these small arteries.
Okay.
Now, if the nerves are involved, then we call it a term as peripheral neuropathy. Means the nerve that supplies to the foot, somehow they are involved. So the sensation part is lost.
Okay.
Then the nerves are also supplying the muscles of the foot. So the muscle starts becoming weak. Because the muscle starts becoming weak, the foot bones, which takes our body when we are walking, starts, getting deformed. So that is the reason that the pressure on the body over the foot at different points starts in a haphazard way, leading to some areas which having more pressure, some areas less pressure. Yes. And as this slowly and slowly progresses, that area which bears the maximum pressure starts, giving a small ulcer.
Yes.
And hence it is important that we detect them early. The other risk factors involved is that the diabetes, it involves the vessels. Vessels means that the vessels get slowly sclerosed. They become little thickened, and the small capillaries becomes blocked. So what happens is that the nutrition, the oxygen doesn't go to the foot, to every part of the foot. And also the autonomic neuropathy occurs where there is some sweating issues are there, and all this becomes a vicious cycle. And there is an callosity formed, and in the middle of the callosity there will be a small ulcer, and this ulcer will slowly, if neglected, may reach even the muscles, and eventually it may reach the bones, and it may become a chronic ulcer. So it is not a good sign to have a diabetic foot ulcer. It usually leads to a lot of inactivity in the patient. Mm-hmm. The patient is bound because of the pain, because of the discharge, because of the not able to walk properly. His daily activities are hindered. He is not able to move freely. Yes. So there is a lot of problems that occurs. I mean, the people should understand that it is better to prevent first. If not prevent, then treat it properly.
Yes. Sir, how neuropathy contribute to developing of diabetic foot ulcer?
Yes, as I have said, neuropathy actually means there is the involvement of the peripheral nerves. Okay. The involvement of the peripheral nerves and the destruction of the peripheral nerves. Now, these peripheral nerves take the pain sensation. So, once they are involved, that the pain sensation from the foot is not being properly by the brain, it is not able to locate that the pain is there. So hence the patient who are diabetes and the nerves are involved, they are not aware of any small trauma to their foot. They are not aware of there is any crack in the foot.
Any kind of pinching.
Yeah, anything, they are not aware of it. So what happens, they eventually they develop some sort of a little bit trivial trauma, and then they realize, oh, they have developed a trauma, and they develop a small wound there, and if neglected, then wound can become an ulcer. It can form ulcer.
So let's talk about the diagnosis and assessment. How can diagnose the pre-diagnosis of diabetic foot ulcer?
Yeah, most of the time you will be surprised to know that the patient comes to our clinic with a small ulcer in the foot, and we tell them, are you diabetic? First thing they say, no, I am not diabetic. Okay. So when we do the blood test, we find them that they are really diabetic and their blood sugar is very high. Okay. Their glycosylated hemoglobin is high, and we'll tell them that you are a diabetic and you are not knowing. So for them it was a surprise that they are diabetic and they don't know. they're diabetic.
Okay.
So basically, clinical examination is very important in the diagnosis of diabetic foot ulcer. And then when we have got some blood tests to be done, there are certain, if the patient comes early, for example, if the patient comes very early, like that, in the initial stages, they will have symptoms like tingling of sensation, some numbness, there will be no ulcer, or there may be a small callosity somewhere formed. At that stage is a preventable stage. We can do some certain test, and there we can tell them that you are more prone to develop a diabetic foot ulcer, so you need certain special care.
Okay. So suppose a person is diabetic. So what are the prevention he should or she should take?
As far as diabetic is concerned,
Yes,
foot ulcer.
diabetic is concerned.
Diabetic prevention is first, if we usually categorize according to the level of the glycosidated hemoglobin. Depending on that, we try to give them either oral medications, or if they're very high, we usually give them insulin also, and ask them that they should have a good lifestyle, which will include at least a daily exercise, and a diet program is given. So we have a multi-speciality team working. So we do refer this patient to our endocrinologist and to a nutritionist, so they take care of this. So as I am a surgeon, so I will take care if there is any foot ulcer or anything, but at the same time I do send this patient to my specialist, to my nutritionist, to my physiotherapist, and also to orthodontist, anybody who is to be involved in that, so that the patient gets a complete treatment.
Okay. Sir, suppose a patient comes to you with diabetic ulcer. So how do you diagnose them? What are the diagnostic treatment, diagnostic pattern you have?
See, if the patient has already come to me with a diabetic foot ulcer and patient is diabetes, then I know that is a clear-cut case of diabetic foot. So what now I am interested is to know whether the patient is having a good blood supply to that area or not. For that, we usually do a Doppler study, peripheral artery, to see what is the flow of the blood to that area is there or not, how much is there, and is there any arteries also involved. Because diabetic foot ulcer and peripheral artery disease, these two combined is a very deadly situation. These patients are more prone to develop diabetic foot ulcers. So we would like to know, or it is just started, then the investigations will be just limited to that. Sometimes we have to do x-rays to see the bones involved or not. Sometimes we have to do MRI of the foot also to see whether the disease has spread inside the bones or it is going somewhere else. So all these tests are to be done once a diabetic foot ulcer is developed in a patient.
Okay. Sir, what is the role of ankle brachial plexus index?
Ankle brachial index, ABI, is a method to know actually the perfusion of the blood, what I was talking. So they will take the blood pressure measurement at the arm, and then they will also take at the foot, and then the ratio is there. So if the ratio is less than 0.9, then we call it the patient might be having a problem with the peripheral artery disease. And if it is less than 0.4, then it is critical. I mean, these patients require definitely some kind of another mode of treatment for them not to develop or not to have the progression of the foot ulcer. But nowadays people are doing other tests, like they are taking toes index also. They are taking
Toes index.
toes.
So, what is toe index?
Toe index means at the instead of taking at the ankle joint, you put certain instruments or certain measurement thing in the toes, and you see how much pressure is there in the toes. Then there are other methods also which can be done, but basically we need to see the ulcer, what is the site of the ulcer, what is the depth of the ulcer, whether it has involved any bones or not, and at the same time we want to see what is the blood flow to that particular area. So that this minimum investigation should be enough for a patient to that. In some other situation, definitely other investigations are required. That depends upon the treating surgeon who according to the patient severity, he will decide what to be done.
Yes. Sir, suppose a patient comes to you with diabetic foot ulcer. Already wound is there. So, what are the principle of wound management once a diabetic ulcer is there on the foot?
Yeah. So the principles of wound management of a diabetic foot ulcer will depend
Yes, sir.
on what is the site, what is the depth of the infection, and what is the other involvement or not there. So there we can divide them into like three parts. One is the wound itself, that is the what we are going to do with the wound. The second thing is, at the same time, we must emphasis on the glycemic control, by means blood sugar control. That is important. And the third point will be that at the same time, when we are going to give this wound care, are we giving some adjuvant treatment or not? Like, for example, we are giving some antibiotics, or we are giving other things that can help in healing of this wound. What is our aim? Our aim is that this wound should heal. So what all we should do to make this wound heal? So first of all, if this wound is not infected, it's a clean wound, then we can do dressings. Simple dressings are required, and we should see that there are no pressure on this wound, and for that we can do certain things to you can offload the pressure. Offloading we can do. For there we can collaborate with our orthotist, and then we tell them that they have to prepare some footwear like this, where this can lead to healing. And if the wound is an infected wound, then obviously we need to debride this infected wound. Now why we need to remove the infected part is that once we remove the infected part, the oxygen supply, the antibiotics, all goes much better into the wound, and the healing is improved, and healing is faster. And then we have to be very strict on this sugar control. We have to tell the patient that your glycemic control should be very strict. Sometimes they might have to be shifted to an insulin therapy, and sometimes they may continue with that other oral hypoglycemics what they are taking. Now, as far as the dressings are concerned, now there are various types of dressings that are available in the market. To say this is better or this is better is a controversy thing. Each company will claim mine is better, but the whole point is that the dressing should be moist. The wound should not get dried up, and it should be kept moist, because moist wound, the healing is better. The healing is faster. There is no need to keep. There is a myth that you keep the wound open. No, the wound should not be kept open. It should be dressed properly, and it should be kept with moist. Now there are various agents available which help in the healing process. Now if I tell the names, it may not go to the public, but they should know that their doctor, whoever is treating, will give them a good dressing so that the wound heals faster. Now, if sometimes when there's infected wounds, we take also culture and we see that what type of bacteria is there and what antibiotics to be given, so that it again helps in the healing of the wound faster. And then, of course, then we have got that we sometimes find that this wound is very infected. It is having dead tissue. Sometimes we find maggots in that, worms going on. So all these patients, we need to have a surgery done. Now the principle of surgery is remove the dead tissue as much as possible and make the wound clean as much as possible when you are going to do surgery on this patient. So when we are doing this, we are helping the patient in healing of the wound faster. Because if you keep a dead tissue there, then it becomes a medium for bacteria to grow, and it can spread slowly.
The
So
infection will be spread and the wound will not be healed.
will not be healed.
Sir, you told na debridement. People are doing, sir.
So they don't understand debridement.
Yes.
Debridement actually is a surgical terminology where we remove the dead tissue. We keep the normal healthy tissue and we remove all the dead tissue that is available.
Okay.
Once the dead tissue is removed, and then we, in the post-operative period, once the surgery is done, we do dressings on them for a long time. Maybe sometimes we do for 7, 10 days, 15 days, 20 days. And then we find that the wound has covered up. Then we either do maybe a grafting has to be done, skin grafting. Sometimes if the defect is too much, then we may have to give a flap cover. So all these are basically various surgical terms. But people should remember to come to us at an early stage.
Yes.
If suppose they have neglected and they have developed ulcer, come to us before it gets very bad. Now what I understand by a bad situation will be when it starts giving pus, purulent material.
Yes.
Then they should, this is not a good sign. When it smells very badly, the odor that is coming from the foot is very bad. When the color of the foot is changing, it is becoming, like bluish, blackish, that means that area is becoming dead. They should come quickly to us, because we want to save as much as foot as possible. Suppose if you remove one toe and you're able to save the full foot, then it is okay. We can still say okay, that toes we can replace by artificial, and it will be patient will
without artificial also
we can walk also. And that is the thing. The whole thing is that prevent the infection.
Yes.
Keep the glucose under control, come to the doctor as soon as possible and get the necessary treatment. The foot is so important that
Yes.
if you lose your foot, your life I may not say come to a standstill, but you will have a lot of problems.
Yes.
But nowadays, obviously with good processes, things are changing. But my question is, why to come to that level? Come early. So, and this is that the podcast should help, that people who are diabetics should come early to us, not only for checkup, but if they develop an ulcer, come early so that we can help them in a better way.
Always the things what God has given to us, that is always better. How much money will invest?
We should keep them.
Yes, we should keep them.
Not lose them.
We should keep them before to keep them. We have to be well educated about all these things.
Yes.
Sir, basically when the ulcer starts, basically a patient come with a diabetic foot ulcer. As you have gone through a lot of patients since long time, so what you notice, like a patient come ulcer with which area, the more prone areas of the foot?
Mostly the foot, the plantar aspect of the foot they will develop. They will develop at the pressure points. So the pressure point are the below the first toe and the fifth toe in the heel. These are the reasons. And also the toes, because they are the distal most part of the body from the heart. So, and it is so much that we are wear and tear and walking, and because of the diabetic foot, neuropathy and the microvascular problems, the toes also I have seen gets affected the earliest.
Deformity started.
Yeah, deformity also starts in the various forms of deformities are there, but the ulcer will somehow form there. The other is sometimes we find in between the toes, intertrigo region also we find the ulcer. And sometimes we find on the dorsum of the foot also some ulcers. Those are mostly because of some trauma, because scratch or some trauma, something has fallen over and it is not healed and suddenly it has become infected. So these are the main areas where we find the ulcers.
But basically due to the improper weight,
yes,
ulcer forms, right?
Yeah, as I have told in the start of my podcast, that the muscles, intrinsic muscles of the foot are affected. They also get slowly very weak because of this muscular neuropathy.
Yes, sir.
There are 3 types of nerves. One is the motor nerve, that is also getting affected. So what is happening? Our pressure on these muscles and the bones are getting, in a different way they are getting distributed. So, and hence the patient wants to keep their weight stable. So he's doing a lot of unnatural exercise or with these muscles and with the bones, and hence slowly these bones are getting deformed, the joints are getting deformed, and they will develop ultimately some foot deformity. So once the foot deformity starts developing, then the pressure is also in some different changes, and then there will be small hard thing form, callus formation will form. Slowly the callus form will, then there in the middle there will be one ulcer. So when majority of the time we see that a nice callus and an ulcer is there. So these are the patient where we tell them that they have come little late to us, but still that is a salvageable point. They can salvage. The not salvageable point is where they developed infection, pus is coming, and it's becoming blackish, bluish. That is the point where we have to do some surgical thing which we don't want to do. That is the thing.
Sir, I have studied one thing when in my study. There is a Wagner signs 1, 2, 3 for like stage 1, stage 2. Is
Yeah.
there something you see?
Yeah, we see.
Stage 1 what happens, stage 2 what happens?
No, see, these are all surgical or Wagner's classification is there. Depending on the 1, 2, 3, 4 classification is there. That is the infection, normal, like that. But for the lay public, that is may not be so helpful.
Like suppose a small callus form, that is stage 1.
Yes.
If there will be small wound from stage 2, something
Yes.
like that, the general public will understand. Okay, I'm right now. The callus has formed means I have to be rushed.
No, I don't want the general public to know the Wagner classification, because that is for us to know. I want them to come to us when the callus is not formed. That is number.
Callus is not formed.
But if they should come to us when the callus has at least formed. Okay.
Because without, if there will be nothing in the food, they can come. Patient comes to you when they feel that they have some problems.
Yeah, mostly they come to us at a late stage. I'm telling you, that is the thing, when they come in infected stage, but they should come at a early stage.
When they've noticed any kind of callus, something
Yeah.
like that, they should rush to you.
Yeah, if they're diabetic and they have noticed some kind of callus and little bit ulceration, that is the best time to come to us.
That was my question actually. I want to ask.
Yeah.
Because people are noticing the same thing in the very lateral stage. That time,
Yes.
the doctor and the patient both are helpless.
We also educate our patients that suppose there is one foot is involved, we tell them that you have to take care of the other foot also. So we ask them whether they are having any tingling sensation, numbness in other foot also or not. That is also important.
Sir, when you see that there is a gangrene is formed, how do you decide whether I should go for a partial foot amputation or total foot has to be removed? How do you decide?
See, nowadays we are collaborating with other department also to know the level of the amputations. Are they what is the level of the amputation?
Yes.
Now, if you do an angiogram where we see the blood vessels flow, if the angiogram flow to the affected part is normal, or there is at least 70 to 80% of the flow is going to that part, then we will only remove that particular infected part of that. See, ultimately we have to give them a functional foot. By functional foot means I can remove that much of the foot. After removal of that foot, the patient should be able to walk. So for that much. So there are certain types of amputation. One is the toes amputation, usually doesn't hamper much of your work. But if you have a 4-foot amputation where you remove the 1/3 part of the 4-foot, then also patient can walk. But after that, if you the gangrene is progressing, that suppose the tissue has become gangrene, that means then the patient will require a below knee amputation, and if it's progressed further, he may require above knee amputations. But majority of the time in our clinical practice, we are doing below knee amputations only. Above knee amputation means it's a serious matter. Patient has come very late to us, infection. But we have done many times above knee amputation also. But when the patient comes to us, majority of the time that with the foot, that is the problem. Foot means either some toes are involved and some um, front foot of the foot is involved, and then we remove all the dead tissue, and we then try to preserve as much as the foot. We try to see where the functional component is present, is able to do it or not. If not, we tell them that patient will require amputation.
Sir, as we have discussed about surgical management or wound management, sir, once the wound management you have done, you have to do the dressing and you have given antibiotics, everything. So then you told that offloading is a part where you offload the foot and so that the weight should not fall on the particular area. So on the wound area, what is the role? If ulcer is there, what is the role of the orthotist?
Yeah.
If a diabetic ulcer patient comes to you, how you think?
Yes, they have a very important role. They have a role during the healing process also, and they have a role once the healing process is also over.
Okay.
Once the healing process is over for the diabetic foot ulcer, they have a role that it should not recur again, because recurrence of a diabetic foot is not a good thing to happen. If it happens in the same area, then again the healing will be prolonged. So when the wound is itself is there, we do send the patient, our patient, to orthotist, and they are able to modify the structural functional component of the foot so that the pressure is not there over that particular area. So they have different types of like footwears, they have different types of casts, and so they are better in this particular field, and it is an upcoming field, and they have been very helpful in our treating our diabetic foot ulcer patients. And it is really good that they are and once they are able to give this facilities to our patients, then they get so much of confidence that they after the ulcer is also healed, they do continue with such orthotist advised as what to be done to prevent it in the future.
Sir, could you explain what are the benefits of customized orthotic footwear and why offloading is required? If a person suffering with foot ulcer, so why he needs offloading?
Yeah, see, the whole thing is that we want to take off the pressure from that particular point.
Yes.
So we have to customize our footwear in such a way that the pressure is not there where the ulcer is there, but in and around there. It is distributed almost equally or maybe less equally, but it is not to be there in the where the ulcer is there.
Okay.
That means the ulcer will get a chance to heal quickly.
Yes. Yes.
Yeah, so that is the whole idea, and they take a lot of measurements. They make it accordingly. Where the deformity is there, they cast the thing accordingly. They put some cushions. All these things are now a big branch, and they do it so that it is very helpful for our patient to go to orthotist and take their help.
Sir, any after orthotic modification of the footwear, any kind of physical exercises needed?
Yes, that is also important. Once you give them this type of footwear, the physical exercise can slow. They improved in the physical exercise. That also helps in the what you call the nutrition going there, the muscles getting strong.
Okay.
So, and hence these are, otherwise what will happen? They will not move from their chair, they will not get up from their bed. So once you give them this confidence that they can walk also and the pressure is offloaded, the nutrition, the antibiotics, everything will go better, and patient will also feel better. Even the glycemic control is better if the patient starts some sort of an exercise, some sort of an walking based on the requirement or based on how much he can do in one day. It helps the patient a lot.
Yes. Nice information, sir.